Okay, and so, all right, I think it should be all good. Let me know if anyone can't see or hear me at all. But yes, hello again, I'm Viana. My research is titled Perpetuation, Prevention, and Operational Facilitation of HIV-related Stigma and Discrimination towards people living with HIV. Yeah, I'll be referring to stigma and discrimination as S&D and people living with HIV as PLHIV. And I did this study under the guidance of Dr. Bruce Akins from UCSF and the wonderful SHIP team. So to start off, I wanted to talk about the HIV treatment cascade, which I'm sure all of you have seen many times before. The Philippines in red is way below the global estimates in the UN/AIDS goals and diagnosis, ART initiation, and viral suppression. And as you can see, there is an 11% on who are on ART with viral suppression. That's quite low. And also key populations or KPs include men who have sex with men, transgender women, sex workers, and people who inject drugs. One or more or these identities combined with HIV contribute to intersectional stigma as well as other forms of stigma. And HIV-related S&D, as we all know, is still very present. As Irving Goffman stated, stigma is an attribute that is deeply discrediting. So here are some selected literature that give some brief snapshots of the status of S&D in the Philippines. The Philippine PLHIV Stigma Index 2.0 in 2018-2019 reported that 36% of PLHIV who are predominantly male, aged 25 to 39, experienced discriminatory remarks from others, including family members and friends. The Philippine HIV and AIDS Policy Act of 2018, also known as the Republic Act of number 11166, announced the goal to eliminate the climate of stigma and discrimination. Additionally, this act allowed youth aged 15 to 17 to do HIV testing without parental consent, which removed a significant barrier in initiating care. In 2021, the UP Population Institute reported that youth awareness of HIV and AIDS dropped to an all-time low. Only 19% of youth aged 15 to 24 had comprehensive knowledge of HIV and AIDS. Seeson et al. Found in 2022 that 66% of MSM anticipated stigma from HIV testing and 44% of MSM mistrusted providers. So these are really high numbers that can help explain why ART initiation and viral suppression in the Philippines are so low. And in 2023, De Los Santos et al. Found that 81% of PLHIV experienced stigma in the healthcare setting. So there's also significant S&D in rural health units, which are usually the only healthcare option for those who live in rural areas. This last study is one among many that really highlights the need to address S&D in the healthcare setting. So now let's talk about the drivers, manifestations, and impacts of stigma in relation to the healthcare setting. This model was pioneered by Neidlade et al. And immediately actionable drivers of stigma, which can be directly addressed, include fear of transmission, unawareness of stigma, negative attitudes, and an unwelcoming institutional environment. Manifestations of stigma include experienced, perceived, witnessed, anticipated, internalized, and intersectional. Also, it can result in discriminatory behaviors such as avoidance, harassment, and refusal to treat. These manifestations negatively impact the HIV care continuum, resulting in reduced testing and diagnosis, broken linkage to care, and inconsistent treatment regimen. Ultimately, these consequences impact the UNAIDS 95-95-95 targets. More PLHIV are unaware or avoidance of their HIV diagnosis. Fewer PLHIV are on HIV treatment, and there's higher viral loads and transmission rates. So let's bring this back to my current project. This outlines my data collection and analysis process. I first developed a semi-structured qualitative interview guide. Then I recruited participants and scheduled interviews with the help of the SHIP staff. I conducted interviews with QIS+D participants either in person or on Zoom. And then I transcribed these interviews and followed up with participants as needed. And then finally, I conducted a framework analysis. This framework analysis involved a full immersion of interview data, iterative coding, deductively and inductively, creating a code book, applying these codes to the transcripts, organizing codes and key quotes into a matrix, interpreting the data for thematic relationships, and then creating final themes. And I also want to thank all of the participants for taking time to do the interviews with me. Across the Philippines, I interviewed 24 participants from 13 facilities between May and June of last summer. They're all in blue. And then I also unfortunately did not have a chance to interview 7 facilities. So now into my results. The 3 major themes were that HIV-related S&D can be perpetuated, prevented, and operationally facilitated by various factors. HIV-related S&D can be perpetuated by religion and culture and also misinformation. It can be prevented by safe spaces, person-centered care, and education, and it can be operationally facilitated by insufficient healthcare workers, outdated equipment and technology, and the lack of confidentiality. So let's talk about how S&D is perpetuated. Religion, culture, and misinformation were the most commonly described drivers of HIV-related S&D. This word map shows some stigmatizing and discriminatory words that participants mentioned and are typically used when society discusses HIV and PLHIV. These words are related to religious ideology and associating HIV with all these negative attributes. These associations can be internalized, which really just diminishes a PLHIV's self-acceptance and mental health. And some participants noted that some people even cringe when they hear the proper terminology for sex-related or HIV-related topics. Unfortunately, many PLHIV experience S&D within their own families. This first quote describes an example of intersectional stigma from being LGBTQ+ and having HIV. Participant 24 said that even though the LGBTQ is very open now in our society, the family or the relatives are not accepting if they're gay or they're lesbian. If you're gay, you have hopeless boys or countless sex guys, and it'll be worse if you get the HIV or other STIs. The second quote describes how people are very repressed because religion and culture limit education about sex and HIV. Participant 6 said that because of the culture and the religion, we don't want that to be introduced to the students. So it's very systemic because we want them to get the information, but we are not giving them the information, and add that to the internalization of stigma. Because at home, we're just going to be told to not do it or you should stay away from that. So they're not really explaining what it is. But again, I'm not blaming them because it's possible that they also do not know because of lack of information, the access to the information. Some ways that S&D can be prevented is by creating safe spaces, providing person-centered care, and promoting education. The HIV Treatment Hub was commonly described as a safe space for clients, where HIV providers are typically knowledgeable about HIV-related S&D and they have zero tolerance for it. Counselors and case managers are really instrumental in providing person-centered care, reducing one's self-stigma, and empowering clients. Also, some participants described community educational presentations at schools and companies, which helps increase awareness and understanding. This first quote describes a participant's zero tolerance for S&D. Participant 12 said that whenever I hear of misunderstanding or misinterpretation, I always tell them that's not right. I always correct them because if you don't correct them, then everything will just move, multiply, and the information will go a long way. The second quote describes how a participant does motivational counseling. Participant 5 said that even if you have HIV, you're still a normal person. You can do work, you can reach your goals or achievements in life, you can become a professional someday, as long as you're in treatment. Here in the Philippines, we have a lot of people living with HIV, almost 40 years or 50 years still in life, still doing their work. That's the way I can motivate them, especially to the young living with HIV. And this third quote describes how a participant sends educational videos to staff outside the HIV treatment hub, which allows them to be more understanding and considerate. Participant 22 said that our staff is more open-minded, more understanding. They have more compassion and empathy to these patients, whereas outside the treatment hub is opposite. I send videos about SOGI, about history of pride, about different documentaries regarding gays, lesbians, about transgenders, like that. I think for those people who watch the videos, I think they're more considerate now. They're more understanding and open-minded about it, that these people actually exist. Despite the factors that help prevent S&D, there are still some operational shortcomings that facilitate S&D, such as not having enough healthcare workers, having outdated equipment and technology, and lacking confidentiality. Oftentimes, healthcare workers can't control these things. This word map shows some key points related to these operational facilitators. So not having enough staff, resources, and equipment makes it really difficult to provide quality care. Some facilities don't have a proper EMR or electronic medical record system, and they rely on paper documents, which can reduce time and capacity for quality care. A few participants noted that some staff members who don't directly work at HIV treatment hubs tag or flag records, which is a discriminatory behavior. And due to COVID-19, some treatment hubs were displaced and moved to a different space that is not really conducive for privacy or confidentiality. So this first quote describes how some clients are impatient when they have to wait for a long time due to being short-staffed. So participant 2 said that some clients already in the maintenance stage with good target CD4BL, but because they know that they have this disease and they have a disability card, they will feel that I can still demand this because I'm this. And also they easily complain for long waiting in the treatment hub, or there's a new staff who is not experienced yet to really handle them. The second quote describes how a participant referred a client to a different facility for surgery, but the client experienced S&D there. Participant 8 said that I referred the patient to the surgeon who was on duty. The surgeon did not want to take up the case, and he asked me if I can refer that client to another facility. I was a little bit mad and angry at the time because why can't you operate on this client? You just have to adhere to universal precautions at operating. There's no special treatment for HIV. And this last quote describes how a treatment hub was displaced due to COVID-19 and their makeshift space isn't very private or confidential. Participant 20 said that it's supposed to be really for counseling just like that, because now we cannot accommodate the patients who come in because there are those who just like to, loaf around, sit down, because they can feel like this is a safe space, they can stay here for a while. Maybe they will drink coffee or talk to somebody or talk with others. That used to happen to here, but in our previous space. So in conclusion, increased awareness and activism are imperative to reduce HIV-related S&D and to improve the quality of HIV care and treatment adherence rates. Perpetuation, prevention, and operational facilitation can be addressed by various policy recommendations. The first policy recommendation is to require healthcare workers in all levels of the healthcare system to complete competency trainings for chronic infectious diseases, including HIV. The second is to build resource capacity in HIV healthcare workers, updated equipment and technology, and spaces for confidential counseling. And the third is to revise operational protocols and policies in the healthcare setting to systematically reduce S&D at all levels of client engagement. These policy recommendations may be challenging because governmental resources and support are not guaranteed, but given the status of HIV and stigma and discrimination in the Philippines, these are things that should be really focused on. And yeah, that ends my presentation. Thank you so much. If anyone has questions, definitely let me know. Thank you.